Again, dear audience, welcome. I'm Mariangela Pellegrini. I work for the ERN-EuroBloodNet as Patients Program Manager, and it's my great pleasure to welcome all of you on behalf of the ERN. As you may know, today we have a lecture that is part of a cycle of webinars dedicated to sickle cell disease and addressed to patients and their family, whose aims is to disseminate educational topics among the sickle cell disease community, so to patients and their families. And one important thing to say is that we have identified 11 topics, and those topics have been chosen directly by people living with sickle cell disease from answering to a survey. So today we are at the 6th lecture. We have already tackled many topics. Today we are going to talk about sickle cell disease and immune disease. With us, we have, as usual, an expert of this domain. I'm very glad to introduce you, Dr. Slimane Allali, and hope to pronounce it properly. He's head of the Reference Center for Red Cell Disease and Sickle Cell Center at the Necker University Hospital in Paris, in France, which follows 700 children, and is also head of a healthcare network for sickle cell children in the Parisian area. And so it's my great pleasure to pass the floor to you, Dr. Allali. Thank you very much.
Thank you very much. So thank you for the introduction. My name is Slimane Allali. I'm a pediatrician in the general pediatric and in the sickle cell center of Necker Hospital in Paris. And I also work for the research in the laboratory of molecular mechanisms of hematologic disorders and therapeutic implication in the Imaging Institute in the laboratory of Professor Olivier Hermine in Paris on innate immunity and sickle cell disease. So I'm very glad to discuss with you today the theme of sickle cell disease and autoimmune diseases. I have no conflict of interest to declare. I will go on quickly. So the learning objectives today can be summarized in 3 questions. The first one is, how could sickle cell disease promote autoimmunity? The second one is, are patients with sickle cell disease more prone to autoimmune diseases? And the last one is, what are the therapeutic implications of autoimmunity in sickle cell disease? So let's start with the first point. The definition of autoimmunity can be defined as immune response leading to a reaction against a self-antigen, that is a molecule that is a normal constituent of the body. So autoimmune diseases, they occur when immunity fails to control a subset of lymphocytes, which are autoreactive lymphocytes that become responsible for damages of tissues containing the autoantigen. So if we look here at cells from the body, you can see the red triangle. It's a self-antigen, that is a molecule that belongs to the body of the patient. Here we have an element of the environment, an infectious agent, for instance, and there's also an antigen with similarity with the self-antigen on the cell. Okay, and now we have a white blood cell, lymphocyte, that will recognize this antigen, which is normal. But the problem is that it will also mistakenly recognize the self-antigen. So it will, the lymphocyte will produce antibodies that will target the self-antigen, resulting in the end in the production of mediators, cytokines, and mediators that will damage the tissue, damage the cells. So that's the principle of autoimmunity. And the breaking of peripheral tolerance, this mechanism that we have seen, may be caused by several mechanisms. The first one is molecular mimicry. It's just the fact that there are similarities between some antigens on the cells of the patient and some antigens on elements of the environment, such as infectious agents. But it's not all. We have also different factors that would promote autoimmunity, including inflammation, abnormal leukocytes, abnormal cytokines, the inflammatory mediators, abnormal complement. Complement is a set of small proteins that activate themselves in cascade, resulting in a kind of complex that will attack the cell membrane of the pathogens, or should do so. And also, type 1 interferon is produced, and the sustained production of type 1 interferon, which is a cytokines or mediators that promotes, that plays an important role in immunoregulation and T cell proliferation. This type 1 interferon, when it's produced too much, it also plays a role in autoimmunity. And why is it important? Just because we will see later that all these parameters are increased in patients with sickle cell disease. Inflammation, abnormal leukocytes, cytokines, inflammation, complement activation, type 1 interferon, all these characteristics are upregulated, are important in sickle cell disease. So in autoimmune diseases, there's also an importance of genotypes. Some specific genotypes, HLA, B27, for instance, may predispose to autoimmune diseases, but it's not really the problem in sickle cell disease, which is linked to a single mutation of the beta globin gene. The important thing is that the main triggers of autoimmune diseases are infection, and we know the role of infection in sickle cell disease, and the importance of infection and the increased susceptibility to infection. So now let's have a look at the classical pathophysiology of sickle cell disease that you all know, but it's still interesting to say that the sickle cell disease is primarily a disease of the red blood cell, with the single mutation of the beta globin gene that will result in the polymerization of hemoglobin tetramers in hypoxic condition that will form long fibers that deform the red blood cell into a sickle, resulting in two phenomena, vasoocclusion and chronic hemolysis. So that is the classical pathophysiology, and it's very important. But in the last years, there has been growing evidence on a role for other cells than the red blood cells, that is the innate immune cells. So the red blood cell still keeps a central place in the pathophysiology with the cycling, increased adhesion to the endothelium, but through the release of heme, the red blood cell, hemolysis, can also activate many different innate immune cells, including the monocytes, which are leukocytes that produce huge amounts of inflammatory mediators, such as TNF-alpha or interleukin-1 beta, that will in turn activate endothelial cells and activate the endothelium, leading to adhesion molecules. These monocytes, they can also play a positive role when they scavenge cellular debris from the endothelium. You have outside the blood vessels, you have macrophages. Macrophages are like monocytes, they are huge producers of inflammatory mediators, and they can be activated via the same receptor, TLR4, which is expressed by almost all innate immune cells, actually. And they contribute to the production of inflammatory mediators and also to the recruitment of monocytes to tissues. Neutrophils are major actors of adhesion of the red blood cell to the endothelium, and they also promote vasoocclusion. There's a release of a DNA fiber that are called neutrophil extracellular traps. So all these cells are very important, but they are not the only one. We have also the platelets that are activated in sickle cell disease via TLR4 as well. that can also contribute to inflammation. We have the release of mediators. We have other subset of more rare lymphocytes or white blood cells, such as the invariant natural killer T cells that produce interferon gamma. We have eosinophils that are activated and produce reactive oxygen species. And last but not least, we have the mast cell, which is an important actor for which we have a particular interest in the laboratory, and who release many different mediators and seems to play a role of orchestrator in this complex set of innate immunity. So sickle cell disease is not a disease of the red blood cell only, and the red blood cell is not the only protagonist anymore. We see that innate immune cells play a very important role. So it leads to the question, how could sickle cell disease promote autoimmunity? First, we have seen that all innate immune cells are important and they are increased in absolute count in sickle cell disease. Almost all cells are increased. And the monocytosis, the monocyte count, is correlated to hemolysis markers, for instance. Also, all these cells, they have the TLR4 receptor that we have been talking about, and chronic hemolysis can activate all these cells in sickle cell disease. As it has been well demonstrated by John Belcher, hemoglobin will release heme will activate this TLR4 receptor, which will lead in the activation of these inflammatory pathways, resulting in inflammatory mediators. And it will also contribute to the overexpression of adhesion molecules, such as P-selectin, and we know the importance of P-selectin, which is a target for new treatments, such as crizanlizumab. So that's an important point, but that's not all. The complement pathway that we have been talking earlier, this set of small proteins that activate themselves in a cascade, this complement pathway is hyperactivated in patients with sickle cell disease. And this is true even in steady state. It's a work that was published recently on soluble C5b9. The name is not important. It's just that it's a marker of the terminal complement pathway activation. And this marker of the complement activation is increased in patients with sickle cell disease compared to healthy controlled, Caucasian or African controls. We have an increased plasma levels of these markers. And an interesting point is that here you have controls, here you have patient non-treated with hydroxyurea, and here you have patient treated with hydroxyurea, and you can see that the complement level, the complement activation level is lower when the patient receives hydroxyurea. So it might be reflecting a beneficial effect of hydroxyurea, as we will discuss later. And the last point is the interferon alpha signaling pathway. This interferon alpha signaling pathway is very important in autoimmunity. It's a discovery of this 10 last years, and we have seen that in the plasma from patients with sickle cell disease, the level is significantly increased compared to healthy control. And when we look at all the genes that could be upregulated in monocytes in response to this activation of the interferon alpha pathway, we look at monocytes from patients with sickle cell disease, and we see that all these genes are upregulated, are overexpressed compared to control. So this pathway, which is very important in autoimmunity, is also very important in patients with sickle cell disease. Here we have what we call a transcriptome. It's the mRNA expression, so it's the expression of all the genes in the monocytes, in these inflammatory cells from patients with sickle cell disease. And you can see that for sickle cell disease, the color are not the same because all these genes are upregulated compared to controls, but also compared to other diseases, other patients with hemolytic anemias that are different from sickle cell disease. So it's not just hemolysis actually that is responsible for this pathway and inflammation probably also plays a very important role. So now that we have discussed a little bit about the pathophysiology and how sickle cell disease could promote autoimmunity, the second point is this one: are patients with sickle cell disease more prone to autoimmune diseases? So autoimmune diseases, first of all, it can be considered as multi-organ systemic diseases, where the immune system will mistakenly recognize antigens from the body as foreign antigens and will react and will attack the tissues. But the important point is that all tissues can be affected. It's really a multi-organ disease, and it's quite important to say that sickle cell disease is also a multi-organ disease that can affect different organs, including the brain, the eyes, the bone, the lungs, liver, and so on. So there is quite a parallel between these autoimmune diseases and sickle cell disease. So autoimmune diseases are quite complex. They can be classified, if we want to make it simple, in organ-specific autoimmune diseases or systemic diseases. So organ-specific can be, for instance, specific of the liver for primary biliary cirrhosis, for instance, or autoimmune hepatitis, which is not rare in patients with sickle cell disease, as inflammatory bowel diseases, such as Crohn's disease or ulcerative colitis, which are diseases specific of the bowel. But we have also what we call systemic diseases, that are autoimmune diseases where the antigen is not specifically in an organ, but is in different organs, different tissues. And the two main diseases in this category are systemic lupus erythematosus and rheumatoid arthritis. So let's discuss a little bit about these two diseases, because they are the most frequently reported autoimmune diseases in sickle cell disease. So systemic lupus erythematosus, it's a very frequent autoimmune disease that affects several organs, as we can see in this picture, including the joints, the skin, the brain, lungs, kidneys, blood vessels. So many organs can be affected through the vessel, actually. It can affect people of all age, but the risk is greater in women of childbearing age, or young women. The symptoms are very varied and non-specific, which may be a problem in patients with sickle cell disease, because non-specific symptoms are also common in patients with sickle cell disease. And they include fatigue, fever, pain, swelling of the joints, skin rashes, photosensitivity, mouth ulcers, and lung and heart abnormalities, such as pleuritis or pericarditis. And as in many diseases, an early diagnosis and early treatment initiation will help reduce damaging the effect of the disease and will improve the quality of the evolution and the quality of life. Now, rheumatoid arthritis, it's a different disease, but it's actually quite similar by some point, because it's frequent. It's even more frequent than lupus. It's a very frequent autoimmune disease. It primarily affects the joints, but it may also affect the skin, the eyes, the lungs, heart, and other tissues. So the joint is very, very important, and the synovial is very important. There is huge inflammation in the synovial that will, in the end, destroy the joint and result in stiffness and deformation. So this disease, this autoimmune disease, affects people of 50 years of age in median, with a greater risk in women. The most frequent symptoms include symptoms of the joints, so the pain, the swelling, stiffness, and deformation of the joint. But there are also symptoms of the skin for rheumatoid nodules, of the eyes for scleritis, for instance, lungs with interstitial lung disease, fatigue, depression, and many other symptoms can be found in this disease. And the anti-inflammatory treatments, like in lupus, have to be started early to improve symptoms and to slow the disease progression as soon as possible. Now, what do we know about autoimmune diseases and patients with sickle cell disease? In the literature, the main autoimmune diseases that have been reported are the two that we have briefly shown: systemic lupus erythematosus and rheumatoid arthritis. And there's a very good review from Bezug in the British Journal of Hematology that summarizes these two diseases. An important point is that there are really overlapping symptoms between these two diseases and sickle cell disease, because they both are systemic diseases with non-specific symptoms. So the diagnosis may be sometimes very difficult, as pain of the joint, of the muscle, fever, elevated inflammatory markers are common in diseases, in these autoimmune diseases, but also common in sickle cell disease. So it's very important that the doctor, when the pain is persistent or is particularly important or recurrent, or that there are some atypical symptoms, it's very important to look for specific symptoms of autoimmune diseases and not to always conclude that the pain is related to sickle cell disease. Otherwise, there will be diagnosis delay for these autoimmune diseases, which can be negative for the patient. So it's important, for instance, for lupus to look at malar rash, alopecia, which is hair loss, photosensitivity, it's a reaction to sun, oral ulcers, pericarditis, pruritus, to look at all these symptoms. Here you have a young woman with a malar rash. It's what we call a butterfly rash, which is not supposed to be seen in sickle cell disease. Here you have a man with hair loss, it's alopecia, which is quite suggestive of lupus. And here you have a young girl with photosensitive dermatitis of the neck. So this is very important to avoid diagnosis delay, as it has been well shown by our colleagues. Now, systemic lupus and sickle cell disease, what do we know? We know that the prevalence in the general population is 1 case out of 1,000. In sickle cell disease, the prevalence is not perfectly well known, but it's clearly increased, as in the literature we have prevalence from 3 to 14 cases per 1,000 patients. So it's clearly increased. The problem is that the criteria, the revised European criteria for lupus that have been published in 2019, and that are very good for the general population, cannot be used for patients with sickle cell disease, because a lot of these criteria, such as fever, joint involvement, cytopenia, the low white blood cell level, the low platelets level, are very frequent in patients with sickle cell disease. And for biological markers, it's the same, because anti-nuclear antibodies, which are antibodies that we look for in lupus and that are quite important in the diagnosis, they are elevated in 50% of patients with sickle cell disease. So we can clearly not rely on these markers, and we have to look directly at more specific markers, such as anti-DNA or anti-Smith antibodies. Now, rheumatoid arthritis and sickle cell disease. What is known? We know that the incidence is very frequent disease, and the incidence is 1 out of 100 patients, 1% of the general population has rheumatoid arthritis. It occurs, we have said, at 50 years of age in the general population. It's the same incidence in patients with sickle cell disease, but it occurs at a younger age. So clearly, there seems to be another risk in sickle cell disease, because it occurs at least 5 years earlier than in the general population. And the suspected mechanisms, apart from the classical autoimmune diseases mechanism that we have been talking about, the suspected mechanisms in sickle cell disease involve ischemia of the joint, synovial ischemia that will result in inflammation and complement activation that increases autoimmunity. Here again, the diagnosis may be difficult because persistent joint pain and biological inflammation is very frequent in sickle cell disease. So we have to use biological markers such as rheumatoid factors and X-ray to help distinguish between the two diagnoses. X-ray because actually it can show erosion of the joints, of the small joint and the large joint as well, but it's often symmetric damage of the joint and that are not typical on the X-ray of what we can see in sickle cell disease bone. But all these markers have to be done if the diagnosis has been evoked, and the first thing is already to evoke the diagnosis when the pains or the joint pain, stiffness and swelling is not really usual or is very important. Now, what about other autoimmune diseases in sickle cell disease? We have been talking about organ-specific, about systemic autoimmune diseases, but there are also organ-specific autoimmune diseases, such as the autoimmune liver diseases, which are not as rare as we thought in patients with sickle cell disease. Here it's a publication from our cohort of patients, and we have been looking at all the liver abnormalities in our patient, and we found that autoimmune hepatitis represents 0.5% of the patient. So it's not as rare as it should be. But the problem is that there are many other causes of liver abnormalities in sickle cell disease, lithiasis, of course, but we can have also ischemic cholangiopathy. We also have vasoocclusion, because as you can see here, the red blood cell, when there is a sickling, it can also obstruct the small vessels of the liver and results in biological abnormalities. We have the transfusion with iron overload that can result in problem of the liver, and we have also the problem with the chelator treatments that can have toxicity for the liver sometimes, infectious hepatitis, and even biochemical abnormality without explanation in more than 2% of patients, and that probably reflects vasoocclusion at steady state. So it's very difficult to evoke the diagnosis of autoimmune liver disease, but it should be done when there is persistent biological abnormalities, and it's important to look at autoantibodies that are specific of the liver. I have not detailed them because it's not the point here, but it's important to evoke the diagnosis and look for it with specific markers, and when necessary to look at histology on liver biopsy when necessary. Now, two other autoimmune diseases. Red blood cell autoantibodies, it's not really an autoimmune disease because it's not always responsible for hemolytic autoimmune anemia, but it's important to know that almost 8% of transfused patients have autoantibodies, that is, antibodies directed against the red blood cells from the patient. And this is a major risk factor for alloimmunization. So when a patient has autoantibodies, the risk is tenfold higher to develop antibodies against the red blood cell from a blood donor during a transfusion. So it's very important to look at it, and it's a reflect of autoimmunity in patients with sickle cell disease. Now, another disease that is very frequent in the general population, diabetes. It's a very interesting wrong example of autoimmunity in sickle cell disease, because diabetes is frequent in the general population. It's one patient out of 1,000, but the prevalence in sickle cell disease is clearly lower than in the general population, and we don't know clearly the reason. We think that there is a role for lower obesity rate, because patients with sickle cell disease are less obesity problem than in the general population, because of hypermetabolism and dysbiosis and so on. But it's not. It might be also reflecting other pathways that we are investigating. Now, just a small work that we have done in our cohort of patients on autoimmune diseases in patients with sickle cell disease. It's unpublished, but you can see here that in our cohort of 700 patients, we have looked at the prevalence of these different autoimmune diseases. And you see that in black, it's the prevalence in the general population in children, and in red, it's the prevalence in our cohort. And what do we have? We have a very increased prevalence in our cohort for lupus, Kikuchi, which is kind of lupus with lymph nodes and specific histology. We have increased prevalence of autoimmune liver disease, inflammatory bowel disease, and anemia and autoimmune hemolytic anemia. So the only disease that is not increased is diabetes mellitus, as we have discussed earlier. Now we arrive at the third point of this talk. The third question is, what are the therapeutic implications of autoimmunity in sickle cell disease? First, what are the main treatment of autoimmune disease outside of the context of sickle cell disease? Glucocorticoids are the most frequently used initial anti-inflammatory drugs in autoimmune diseases. So at the initial phase of almost all autoimmune diseases, the corticoids, which are very powerful anti-inflammatory treatments, not very subtle, but very powerful, can be used and can be efficient. The problem is that they're exposed to many adverse effects, including hypercortisone, adrenal suppression, hypoglycemia, diabetes, dyslipidemia, heart problem, osteoporosis, and so on. So it's very important that during chronic treatment of autoimmune diseases, the doctor has to try to minimize and to taper and discontinue when possible this glucocorticoid treatment. And to do so, we have to use immunomodulatory agents that or biological therapies that will help to stop the corticoid, as we will see. Now, what about steroids, glucocorticoids in sickle cell disease? In sickle cell disease, we know that steroids are not easy to use. Why? Because they are responsible for leukocyte demargination. Leukocyte demargination, the fact that the white blood cells go in the vessel from the endothelium to the vessel. So why is it a problem? It's a problem because the red blood cell in the vessel, through hemolysis, will release heme. Heme will activate TLR4. TLR4 will activate the P-selectin. The P-selectin will stack the neutrophil. The neutrophil will get attached to the P-selectin, which is an adhesion protein. And then there will be a secondary wave of activating signals through E-selectin that will induce the clustering of a molecule that is called MAC1 on the leading edge of the neutrophil that will capture the red blood cells. And this is responsible for vasoocclusion. This is a very important mechanism of vasoocclusion. So steroids, when they induce leukocyte demargination, they can contribute to vasoocclusion and vasocclusive crisis and acute chest syndrome. And this has been well demonstrated in this publication, recent publication in Blood by Walter and all. And now, steroids and autoimmune diseases in sickle cell disease, there has also been several reports showing that there is an increased incidence of vasocclusive crisis and acute chest syndrome when autoimmune diseases are treated with steroids in a sickle cell disease context. So many teams think that it's important to prevent this risk related to steroids by using the transfusion or exchange transfusion program, at least when the steroids that are high dosages, in order to prevent the occurrence of this very severe complication. And the idea is to decrease the level of hemoglobin S in order to prevent the risk of vaso-occlusion. So what about other therapies for autoimmune diseases and sickle cell disease? We have seen the steroids. The other therapies are immunomodulators, such as methotrexate for rheumatoid arthritis, for instance, or azathioprine, and biological agents such as anti-TNF-alpha antibodies, infliximab or other, that are modulating the inflammation and that are very good treatment, new treatment, but they expose to an increased risk of infection. And we know that in sickle cell disease, there is already an increased susceptibility to infection due to functional asthenia. So it's very important when these treatments are used to look at the vaccination and to do it properly, and also to give the advice of immediate consultation in case of signs of infection, such as fever or cough or so on. Other treatment, methotrexate and other disease-modifying anti-rheumatoid drugs are at increased risk of cytopenia, so it's important to know it. And all the specific risk on the liver, the kidney, and so on, that are specific to each molecule have to be known in order to prevent the occurrence, and not to say that the problem is linked to sickle cell disease when it occurs. But overall, these therapies, these new therapies, have excellent tolerance, and in this publication from Necker Hospital, we had very good results with anti-TNF-alpha treatments in several patients with autoimmune diseases. Now I've almost finished, but I would like to say a word on treatments of sickle cell disease in the context of autoimmune diseases, because hydroxyurea is clearly not a treatment that we will use for autoimmune diseases, but it will clearly reduce autoimmunity because it decreases innate immune cell count and it decreases antibody production. It's also one of the effects that is looked for, because we know that the patient with the most benefic effects of hydroxyurea, of course, they have increase in fetal hemoglobin, but they have also a decrease in neutrophil or leukocyte absolute count. And this is very important because it can also decrease innate immune cells and autoimmunity. Hematopoietic stem cell transplantation is clearly a treatment that can cure sickle cell disease, but it's important to say that it can also cure autoimmune diseases because the bone marrow will be replaced by the bone marrow from the donor, and the bone marrow from the donor has not the same susceptibility to autoimmunity. So we have example of patients with autoimmune diseases who had bone marrow transplantation and who were completely cured of their autoimmune diseases after the treatment, even if this treatment was not decided for this indication. And there is also a risk of recurrence of autoimmune diseases, for instance, autoimmune hepatitis, if transplantation, liver transplantation is performed for a patient with autoimmune hepatitis and hematopoietic stem cell transplantation is not done. We have unfortunately observed it recently in a patient from our cohort, but we can have a recurrence of this severe autoimmune hepatitis if hematopoietic stem cell transplantation is not done. So here are the three take-home messages. First, there is an increased risk of autoimmune diseases in sickle cell disease. That has to be known, because if we know that it exists, we will, the doctor will look for these specific symptoms and will not always conclude that the symptoms are related to sickle cell disease. The second point is that steroids, glucocorticoids, should not be used, or should be used very carefully, at least when they are at medium or high dosages. Transfusion should be considered. It's very important. And the last point is that hydroxyurea and hematopoietic stem cell transplantation can be also benefic for autoimmune diseases in sickle cell disease. So thank you very much for your attention, and I will be happy to discuss all the points that you want to discuss.
Thank you very much, Dr. Allali, for this comprehensive and very clear presentation. I see there is already one question in the chat. Also, I would like to say before addressing the first question that if you prefer to address the question orally, please raise your hand and you can unmute yourself and take the floor. So the first question, do these autoimmune disease affect people with sickle cell trait as well in the same ratios?
Yes, it's a very good question. There have been already reports on this subject and question, but we do not know perfectly well yet. What we know is that in sickle cell trait, we don't have the same hemolysis because the level of hemoglobin S is not the same, of course, and hemolysis is not as important. And hemolysis seems to be very important in the mechanisms leading to autoimmunity. So there might be something with sickle cell trait, but it's not demonstrated, and it's clearly not as important as in sickle cell disease.
Thank you very much. Maybe we can wait for a few minutes to see if other questions arrive. Of course, I really encourage the audience because this is a unique occasion for speaking directly with an expert of a specific shaped topic. So I said before, you can both write or unmuting yourself and take the floor as you prefer. And yes, I see a new question. Thank you very much. Thank you very much, very enlightening. Are there differences in autoimmune disease diagnosis and the different sickle cell disease phenotypes?
Again, a very, very interesting question. The publication, the literature on autoimmunity in sickle cell disease is growing, but it's not still as important as it should be. So I cannot answer this question, but I can answer from our core because we had a look at this question. And clearly, autoimmune diseases in our cohort concern patients with SS phenotypes. But as we have really a majority of patients with SS phenotype, I cannot affirm that it's less prevalent in patients with SC phenotypes, for instance. But in my opinion, due to the importance of hemolysis, as hemolysis is less important in patients with SC or S beta plus phenotype, I think that autoimmunity, it's my impression, is that patients with these phenotypes are less prone to autoimmunity, but it's not demonstrated, and it would be interesting to do it in a multi-centric study to answer this very interesting question.
Thank you very much. I pass to the other question. Thank you for the presentation. Do you recommend annual screening of asymptomatic sickle cell patients with autoantibodies, asymptomatic for autoimmunity clinical symptoms?
No, I wouldn't do so because, as we have seen, as autoimmunity is very prevalent, you can have biological markers of or immunological markers of autoimmunity without having the disease, and having this, I don't know, for instance, anti-nuclear antibody in half of the patient, to know that you have this increased markers, it will not lead you to change your therapeutic strategies, because it's very important to first look at the symptoms and look at the clinic. So I would say that the doctors should do this investigation very easily, but not when patient, in my opinion, not when patient are asymptomatic, because it will not lead to introduction of steroids or immunomodulatory treatments or other therapies. But your question is relevant, and it's true that in the general population, when you find a marker that has been looked for sometimes a wrong reason, and you find that it's high, an immunological marker, you will be more careful. So it's not. I wouldn't advise it, but we have to take it into account when we are in front of this positive autoimmune biological markers.
Thank you very much. So right now there are no questions, but of course we can wait again some minutes to see if they pop up, because we have still some moment to spend together with this topic. Here it goes. Any difference between HU versus red blood cell exchange in the apparition of autoimmune diseases?
I cannot answer the question because I do not have the information, and I haven't found this information in the literature. But it's a very interesting point, and again, a very large study with many centers could help answer the question. I think that red blood cell exchange will lower the hemoglobin S level, but there are still many red blood cells, or at least I would say 30% of the red blood cells that are sickle red blood cells and that contain a majority of hemoglobin S. So there is still hemolysis, there is still activation of the endothelium. It has been well demonstrated. There's still adhesion, there's still inflammation. So I don't see why it would prevent the occurrence of these diseases. And another point is that in some centers, and patients with under monthly transfusion program, they are also treated with hydroxyurea in order to improve this adhesion issue. And this will make the question more difficult to answer. But in a retrospective multicentric study, I'm sure we could have an answer.
Thank you very much. As said, we wait 2 minutes to see if there are any questions. So while waiting, maybe I can advertise the new topic that will be after the summer break, the 26th of September. And there will be a lecture from Celeste Bento. He's a laboratory expert from Portugal, University of Coimbra. And she will talk about genetic counseling and embryo selection. So please take note of this day if you are interested also in this topic just after summer break. So I see no new questions arriving. I think we have addressed all the important aspects of the topic.
I see. Maybe,
there is a new.
Yes, maybe.
Yes, now.
Okay.
Everyone just joined. I'm sorry.
I'm completely interested.
Yes. By the way, Ida, you could see the video of this webinar when it will be published on our YouTube, because all those webinars are gathering in our educational channel on YouTube. And I'm sorry you could not assist, but likely there will be the available material for those kind of, I mean, we are not always available, so it's normal, but we can still see the video. Okay, so thank you, Dr. Allali, for being with us and for sharing your time and expertise.
Thank you very much. It was a pleasure.
Anna, there is one question. Is it normal that they have difficulty, I think she meant physician, difficulty finding other disease when you have sickle cell disease?
Yes, I think it's normal because when you have already a diagnosis, that's what we are teaching to the medical students. the problem is that when you have already the diagnosis or the idea of the diagnosis, you can miss the real diagnosis, so you can miss many important information. So when a patient comes for pain at the emergency department and that we know that he is affected with sickle cell disease, a lot of patients or people, of doctors, nurses will immediately say it's a vaso-occlusive crisis. And it's, I would say it's a human normal reaction, but it's the wrong way to do medicine, because you will miss all the other diagnoses that are very important. So it's normal, but it's sometimes that we have to fight again.
Thank you very much. There is one comment, say, thank you, very interesting.
Thank you very much.
Okay, so thanks to all of you for this great debate. Again, thank you, Dr. Allali, for having been with us and shared your expertise. And see you after summer break, the 26th of September. Thank you very much. Have a nice evening. Bye-bye.
Bye-bye. Thank you.